As you can see, we're going to, sorry, just, okay, something happened. Okay, so we're going to talk about lung ultrasound in children. And so today we are opening the gates to the world of lung ultrasound. And here are today's goals. First of all, we are going to go through the whole spectrum of normal and pathological lung ultrasound.
Excuse me, dear professor, we don't see your screen.
You don't see my screen?
Not yet.
Sorry, okay. Okay, just a second. Just a second. Share, okay, now?
Yes. Yes, we see.
Okay.
And also there was a question from auditorium. There is no translation, unfortunately.
Yeah, there is no translation. Just a second. Okay. So, is it okay now? Do you hear me? Do you see my screen?
Yes, we can hear you and see the screen.
Okay, thanks a lot. So, as I said, dear colleagues, today we are opening the gates to pediatric lung ultrasound, one of my favorite professional topics. And here are today's goals. First of all, we're going to go through the whole spectrum of normal and pathological lung ultrasound findings. Then we will talk a bit pleura and diaphragm on ultrasound, and we will finish with potentials of pediatric lung ultrasound and lung ultrasound in general. Let's start with this. What are we able to see when we use a lung ultrasound? First of all, we are able to see only accessible parts of lungs and pleural space. What does it mean? For example, you cannot approach to the mediastinal part of the lungs. And even in those accessible parts, we will see only pathological entities that are in contact with pleura, that are abutting the pleura. So even then, if some pathological entity is in contact with pleura, and if it's, for example, an air-filled cavity, we'll have quite a problem to see it on ultrasound. We can see air-filled cavities, we're going to talk about it today, but they're problematic for lung ultrasound. And now you might say, so why are we using lung ultrasound with so many disadvantages? However, you will see during this lecture that lung ultrasound is very, very useful in everyday clinical practice and can be very important in some diagnostic and clinical decisions. We are using certain lung areas, anterior lung areas between sternum and anterior axillary lines, then lateral lung areas between anterior and posterior axillary lines, and posterior lung areas between posterior axillary lines and vertebral column. However, this is transthoracic approach, and we are also using this transhepatic and transplantic approach to both lung bases. So we use both transabdominal and transthoracic approach. You examine your patient. The only thing matters is to examine the whole accessible surface of both hemithoraces. And my suggestion is to turn off compounding and harmonic imaging, because lung ultrasound is based on artifacts. And now those modern ultrasound devices are trying to take those artifacts from us, and we don't need that kind of help for lung ultrasound. Every examination, I start with transabdominal, transhepatic, and transplantic approach. And first part of this lecture, we're going to talk about this. You'll see how interesting it is. So when the lung base is normal, you will see this mirror image phenomenon. And this is just a supradiaphragmatic projection of liver and spleen. So this is a normal finding. You can see here how liver reflects supradiaphragmatically. However, there are other things that can project over the diaphragm. And here you can see portal venous gas projecting supradiaphragmatically. Look at here. There is a kidney that reflects supradiaphragmatically. And take a look at here. So there is this unechogenic formation within the left lung base, and it could be a cyst, it could be an abscess within the left lung base, but in this case, this was just a supradiaphragmatic projection of fluid-filled stomach. So you have to be patient about it. So what is our first take-home point? Mirror image refers not only to liver and spleen, very important. And now we are going to go through all those pathologies that we can see when we are using transabdominal approach. And of course, the most common one is pneumonia. Look, there is a consolidation with those white hyperechogenic structures representing air bronchogram. Transplannically, again, there is a consolidation with air bronchogram. Look at this. It just didn't look like a normal pneumonic, well, it just didn't look like a pneumonic consolidation because it had this branching anechogenic structure there. And when I put on some color and power Doppler, you can see here that this small part of the left lung base is getting a systemic arterial supply from the aorta. So this was a pulmonary sequestration. Another example of pulmonary sequestration, this is aorta, and look how rich vascularization this part of lung within the left lung base is getting, and this was approved on the CT. So this was a very interesting case. Look at this. So this is normal. However, anteriorly, there is something going on there. Look at this. Normal lung base, and then transhepatically you got some kind of strange round thing. So this is it. You can see this echo structure is quite odd. It's not something we usually see, and I have to say this examination lasted for at least 20 minutes. I tried to see what's going on with this patient. And then I realized that this thing was going up. So this was actually Morgani hernia. And our surgeons, they were not that much convinced that we are right. So they asked for a CT, and CT proved that this was a Morgani hernia. And the thing we saw actually was this mesenteric fat on ultrasound. Look at here, there's a very nice case of herniation of liver through the right hemidiaphragm. This looks similar, however, this was a pulmonary metastasis. You have to be careful because I guess that you think this is a supradiaphragmatic projection of liver. However, there is a thing that just shouldn't be there, and it looks like a cyst. So transthoracic approach showed us that this was a huge 13 centimeters large hydatid cyst. Also, when you're performing this transabdominal approach, you have to be careful about subphrenic space. There is something that shouldn't be there, and with closer inspection, look at here. This is a lung that is not good lung. We'll talk about it later. So there is a left hemidiaphragm, and below the left hemidiaphragm, actually all of this is the complex fluid collection just below just in subphrenic space, just below the left hemidiaphragm. Look at it. And this was a subdiaphragmatic subphrenic abscess proved on CT. So another take-home point would be that you need to think beyond the established patterns and frames. Of course, 99% of time, you will see pneumonias. However, from time to time, if you do your lung ultrasounds regularly, from time to time, there will be some strange and unusual pathologies popping up. But there is another thing why transabdominal approach is important. Again, so this is a normal finding, normal supradiaphragmatic projection of liver within the left lung base. And this is what we saw in one patient. So there is an anechogenic structure within the left lung base corresponding to probably some zone of necrosis or abscess, but we had a problem. You know, we saw that transplanecally, but we couldn't see it transthoracically. And we wondered why. So later on, CT was performed. And look at it. Of course, we saw this abscess within the right lung base very easily. But why didn't we see this left lung base abscess while we were using transthoracic approach? There is the solution. You can approach only to this circumference of left hemithorax. So this is your probe. Between your probe and this abscess, there is a normal lung tissue, normal lung parenchyma. Whenever you have at least a small area of normal lung parenchyma between your probe and any pathological entity, you will not be able to see it. But what is very important here, that this abscess is in contact with a spleen. So transplanically, we managed to get this ultrasound beam through the spleen to this abscess and to detect it. So spleen actually served here as a window to the abscess. So what is another take-home point? Transabdominal approach to the lung bases increases the accuracy of lung ultrasound. So although in some papers you will read that they are using only transthoracic approach, please use both transabdominal and transthoracic approaches. So now you saw how a wide range of pathology we are able to see only by using transabdominal approach. And this is especially important for radiologists. Please pay attention to the lung bases. Even when you're doing a regular abdominal ultrasound, a lot of times when performing abdominal ultrasound, I saw the pathology within the right or left hemithorax. And this 13-centimeter hydatid cyst, for example, was seen during a regular abdominal ultrasound. So now we're moving on finally to transthoracic approach. And here's a normal finding. I guess most of you know that, but anyway, I'm going to tell you that once more. So this is subcutaneous fat tissue. This is intercostal muscle, rib, acoustic shadow. And there is this very thin, hyperechogenic, smooth line representing pleura. And below the pleural line, there are A lines, those artifacts that are equally distanced one from another and resembling actually pleural line. So this is when you're using the longitudinal approach. When you are using a transverse intercostal approach, of course you will avoid ribs. My opinion is that you should use both, and I always use both longitudinal and transverse approach. Now we are moving to this lung sliding sign. So what is lung sliding sign? This is sliding of visceral over parietal pleura. Look at it, visceral over parietal pleura. This is a very important sign. So if you're not sure, and sometimes, you know, from a lot of reasons, maybe you will not be able to say definitely is there lung sliding or not. So then you will turn on this M mode. And when there is a lung sliding sign, you will see this seashore sign. So this is sandy beach and there is a sea over there. This is a seashore sign on M mode. You just put this marker on a pleural line. When there is no lung sliding, so when there is an absent lung sliding sign, you will see this stratosphere, or I like it more, barcode sign, like those barcodes you see you get in the shops. So why this lung sliding is so important? Because if you forget about it and you just see a bunch of A lines and you think, wow, this lung is perfect, there are a lot of A lines, nothing else, you forget about lung sliding, this can happen. So this patient doesn't have like more than half of a right lung, and you said that this lung ultrasound is perfect. So if you pay attention, in this patient, you will see a bunch of A lines. There will be no lung sliding because there is no lungs to slide, no pleura to slide, right? So your face might be look like this after CT examination. Okay, this is a very important take-home point, and I really want to put stress on this, because in most of the papers, whenever there is absence of lung sliding mentioned, they talk about pneumothorax. And of course, this is the most important diagnosis and the most urgent diagnosis. And I agree with that completely, but you should have on your mind that absence of lung sliding or reduced lung sliding sign compared to a contralateral hemithorax can be seen, for example, during and after an extensive pleural pneumonias, can be seen in a hyperinflated lung due to asthma, emphysema, foreign body aspiration, or whatever. So please have this on mind. When we talk about pneumothorax, and when you're beginners, you know, honestly, you really have to have guts to say, yeah, this is definitely pneumothorax based on lung ultrasound. Sometimes it's not that easy, and it comes to you over time. It's not a problem. Experience is doing that for you. Anyway, what is very easy even for a beginner is to exclude pneumothorax as a potential diagnosis. Why? Because if you see lung sliding, there is no pneumothorax. If you see, you will see, we'll talk later about it, those white lines called B lines, there is no pneumothorax. And if you see consolidations, lung consolidations, there is no pneumothorax there. Very easy. The same is to detect lung expansion after the drainage of pneumothorax. So you just put your probe on your patient, and if you see lung sliding, if you see those white lungs or subpleural consolidations, you will know that your chest tube is doing its job. So you don't need chest X-ray to tell you that your chest tube is working. One of the sign of partial pneumothorax is lung point sign. So this is a very, very nice example of lung point sign. Look, there is no lung sliding there on your left up to this point, and from time to time you get lung sliding to this point. So this is a lung point between the absent and preserved lung sliding sign. So this is a sign of just partial, not complete, but partial pneumothorax. So in M mode, this would be the lung point. There was a barcode sign, and there is a seashore sign of preserved lung sliding. So it's not that hard to detect partial pneumothorax. Maybe you noticed, now we talked about A lines and we talked about lung sliding. And now I'm going to show you, just by knowing what A lines are and what lung sliding is, how many pathological entities you will be able to detect. So look at here. This is a, you know that, this is a huge consolidation of lung parenchyma. There is a branching air bronchogram. There is clear pleural effusion. But look at this. It resembles A lines, right? And it's within the pleural space. So look at it. This is a sign of hydropneumothorax, a current sign, like somebody's pulling on and off the curtains within the pleural space. Then again, look at this. This is a thymus, which looks completely normal, and its left border is free. But look at its right border. There's something that looks like A lines that covers this right part of the thymus, and this is one of the signs of hyperinflation, in this case of the right lung. Now look at this. Again, consolidation, again pleural effusion, but now we have A lines, we can see A lines now within the consolidation. So this is a sign of air-filled cavity. In this case, this was an abscess. So let's go in a bit more detail here. So this is a pleural space. There is a lung surface, lung parenchyma, and A lines within consolidation. Look here. This is tricky. This is tricky when you perform lung ultrasound, especially in patients with long-lasting pleural pneumonias, when this pleural effusion is completely organized. Sometimes it's very hard to distinguish it from the lung parenchyma. And it's one of those cases, one of those examples. So there is an organized pleural effusion there. This is the surface of the lung. So within the lung parenchyma, you can see again A lines. And next to those A lines, there is kind of mixture of fluid and air. And this was an abscess. Anyway, please pay attention. Air-filled cavity, you can detect only if you see A lines within the lung parenchyma. If you see anything else, like part of white lung, we will talk about it later, those B lines within the consolidation, this is not an air-filled cavity. So look at here, again, multiseptated pleural effusion. This is the lung parenchyma. And within the lung, you can see this white part of the white artifacts. And this is just an interface between the consolidated lung and the normal lung. Now look at here, again, lung, and within the lung, you can see those white lines, those B lines, compact B lines. Looks like white lung within the lung, but this is not an air-filled cavity. This is just the interface between the consolidated lung and the normal lung parenchyma. And now we're coming to those B lines. So you already saw them. They're white. They extend from the pleural line. They are clearly defined, hyperechogenic, reach the bottom of the screen, erase the A lines on its path, and they move with lung sliding, which you can very nicely see here. I always like to make things as simple as possible. So if you have a few B lines and in between you have those A lines, this preserved normal lung ultrasound pattern, this is called, let's call it black and white finding, and this is an interstitial edema. At the other hand, you can see this white finding. So what is this? This is a compact pattern of B lines. Look like a white lung, white finding. And this is the sign of an alveolar interstitial edema. So what is practical importance of B lines? One or two B lines within one ultrasound section, we think that they are without significance. If they're diffuse, compact, they can be a sign of lung edema, cardiac edema, interstitial lung diseases, neonatal lung diseases. If they're focal, they can point to pneumonia, not necessarily, but they can. And what is very important, and we mentioned that earlier, they exclude pneumothorax. So when you see B lines, there is no pneumothorax there. So as you can see, B lines are very, very important. But there is a huge but there. A lot of times, and most of the time, they're non-specific. So another take-home point would be correlation with clinical and lab findings is essential when you're performing lung ultrasound. And please don't be afraid to qualify lung ultrasound finding as non-specific, because sometimes lung ultrasound findings are definitely non-specific. And now we move on to lung consolidations and all the things we can see. Some of them we already mentioned within the lung, the consolidated lung parenchyma. First of all, sometimes we don't see anything apart from the vessels, and it's called hepatization of lung parenchyma. There's a small pleural effusion there. Then you can see this, sometimes this beautiful branching air bronchogram within the huge consolidations, and it's very characteristic, definitely, of pneumonia. Then you can see parallel air bronchogram in passive pneumonia, in this case due to massive pleural effusion. Then you can see dynamic air bronchograms. This is a centrifugal movement of air through bronchioles, and it tells you about the patency of bronchus, and it excludes atelectasis. So look at here, dynamic air bronchogram. Look, the air moves through the bronchioles. Then again, there is a fluid bronchogram when you see fluid, mostly it's inflammatory content within the bronchus. And here you have to turn on your power or color Doppler not to mix fluid bronchogram with a vessel. Then if there is an involvement of two adjacent lobes, there you can see an interlobar fissure very nicely. Sometimes you can see both interlobar fissures. This was obviously a right side, right lung. Then you can see within the consolidations those small hyperechogenic foci. Look at it, a number of them, and they can be a sign of air trapping, but also you will see those small hyperechogenic foci also when there is a re-aeration of the lung. So a lot of times when the child is getting better and this pneumonic consolidation is getting back air, you will see it to look like this. So this is re-aeration of the lung. Lung is getting back to the consolidation. One of probably the greatest advantages of lung ultrasound is this ability to detect even the smallest zones of necrosis, those hypoechogenic zones. Look at it. It's like 3, 4, or 5 millimeters, and there is no way that you will see those using chest X-rays. Even sometimes it's problematic on CT, but with chest X-rays, definitely there is no way that you can see it. And you know, you told me that there are a lot of pediatricians now listening, and you know how important this is for treatment of those patients. This is a huge abscess. This is actually a huge area of necrosis with some particles of air. So this was abscess, and you can see here a vessel going around this huge zone. And I would like you to remember this kind of echo texture of the lung. So whenever you see this coarse, hyperechogenic echo texture of the lung, this is a pre-necrotic lung. So just 2 days after, look, there are areas, clear areas of necrosis. Few days after that, a number of necrotic areas within this lung. You should also pay attention to thymus and the region around it. So this is a normal thymus. Look at it, look at it. There is a consolidation just next to the thymus, and there's some air bronchogram in there. And then again, you can see a pneumonia on both sides of a thymus. Very rarely seen, but in this case, this was the case in this patient. So 2 pneumonias next to the thymus, bilateral pneumonia. Also, you can see pulmonary metastases. They always have this round edge. So those 2 are metastases from Wilms tumor. And the thing is that when you see such a small rounded hypoechogenic subpleural area, you have to think about metastasis, but also we saw exactly the same images in patients with pulmonary thromboembolism. So you have to be patient with that. Now, just a few words. I know that most of you know about pleura, know about pleural effusions, because you know we started to use ultrasound decades ago for in that purpose. So anyway, just a few slides about it. Those modern ultrasound devices we are using today are actually enabling us to even distinguish between visceral and parietal pleura, which was impossible like 20 or 30 years ago. And here you can see parietal pleura that is very thin and just a slightly thickened visceral pleura here. Then again, parietal pleura, very thin, small pleural effusions, and thickened visceral pleura. I guess you know this. Pleural effusion, for pleural effusions, ultrasound is a diagnostic modality number 1. But the thing is, it's not just a diagnostic modality number 1 for detection of pleural effusion, but also for characterization of pleural effusions. Is it clear, as in this case? Is it a bit very thick? Is it just a bit septated? Is it roughly multiseptated as this one? Are there some fibrin layers on visceral or parietal pleura, etc., etc.? So very good imaging tool, and I would say currently the best imaging tool to assess the character of pleural effusion. And this is a very nice example. This is a patient that had both ultrasound and CT, and you can see that this consolidation on ultrasound corresponds to this one on CT, and on CT you can see this massive pleural effusion, and it looks homogeneous. It looks just you need to put your chest tube in there and you will help your patient. However, this is why ultrasound is so important, because pleural effusion on ultrasound you can clearly see is multiseptated, it's almost organized. So this is not the patient for placement of chest tube. You would get like 1 or 2 milliliters of pleural effusion. This was the patient for video-assisted thoracoscopy, which was performed, and this was the finding within this pleural space. A huge number of those thin septas within the pleural space, and the child was getting much better after this surgical intervention. Very nice example also, transhepatically. Look, there is a hepatization of lung parenchyma. There is a small pleural effusion and only 2 septas within it. After 48 hours, the child wasn't getting better, and the pulmonologist sent to us again this child for an ultrasound. Look at it. This consolidation, it's not much better than the previous exam. And look at this pleural space, not 2, but like 202 septas within this pleural effusion now. So we alarmed our pulmonologists, told them that the child was aggravating, and it was aggravating both clinically and radiologically. So the therapy was changed, and the child was getting better, of course. I like this slide very much. Look at this. Bedside radiography has a sensitivity of 39 to 57, only 39 to 57% in detecting not any, but large pleural effusions. So please do not perform bedside radiographies for pleural effusions. Just put your probe on your patient, and within 10 seconds, you will know exactly what is going on. Just 2 slides about diaphragm. So maybe you know, maybe you don't, that on ultrasound we can assess the movements of both right and left hemidiaphragm. We are doing that using an M mode. We put this mark on the right or left hemidiaphragm, and when the child inspirates, this curve is going up. When it expirates, it's going down, and you measure the amplitude from the end inspiratory to end expiratory phase, and it should be more than 4 millimeters, and there shouldn't be a difference more than 50% between the amplitude of movements between right and left hemidiaphragm. And when you are measuring, please always measure from the upper edge to the upper edge of the curve, or from the lower edge to the lower edge of the curve. So this is normal. Those are normal movements of right hemidiaphragm, and here it is within the left hemidiaphragm. Here you can see in this short video normal movements of right hemidiaphragm and left hemidiaphragmatic paresis. Look at this. This is not the flat line, but just a bit curved line. So this was a hemidiaphragmatic paresis, iatrogenic one after cardiac surgery. And now we're approaching slowly to the end of this lecture, and we're going to talk about potentials of lung ultrasound. And the first one is, of course, chest X-ray number reduction. And here you can see a trend of decrease of the number of chest X-rays per hospitalized patient at the pulmonology department in our hospital. So within 5 years, we managed to decrease the number of chest X-rays for 41%. And this is how it looks like in 2014. You can see the number of chest X-rays in comparison to lung ultrasounds, and 5 years later, they're almost level, just chest X-rays and lung ultrasounds at our pulmonology department. In 2016, we published this paper comparing lung ultrasound and auscultation, and we concluded that actually all those consolidations that were smaller than 30 millimeters were highly unlikely to be detected by auscultation. You can say we're kind of visionaries, because now more and more papers suggesting to use less stethoscope and more ultrasound. And of course, I don't want to say here that you shouldn't use stethoscope and auscultation. Of course, it's massively important. It's very, very important. But just have on your mind that lung ultrasound is a very nice accessory imaging tool that can really help you in your everyday clinical practice. Here you can see that in detection of community-acquired pneumonia, lung ultrasound really has this very high sensitivity and specificity compared both to radiological and clinical parameters, even to lab parameters. And this is very important. I will have a short break here. So look at here. There is obvious alveolar interstitial edema, and I think you will agree with me. So this is a compact pair of B lines. And this was a baby that was lying in supine position, so lying on its back. And this was a right lateral lung area. So this was a right lateral lung area. When I asked the nurse to move the baby to left lateral decubitus position, just with that slight changing of the patient's position, at the same site, this completely pathological ultrasound pattern cleared up and became a normal ultrasound pattern. And all that in only 28 seconds. So just by moving the child on its side, the pathological pattern completely cleared up. So this is another take-home point. Potential of lung ultrasound for pulmonary rehabilitation is huge because it points to the poorly ventilated areas and tells you how to change the patient's position. And just by simple changing of patient's position, you can really do really well to your patient, and you can accelerate his recovery and recovery of the state of its lungs. There's some more potentials, of course, in NICUs, and Professor Yinglier will going to talk to you about it, or maybe he already talked, I don't know. There's a dynamic follow-up, correlation with clinical and mechanical ventilation parameters, helping decision-making, evaluating surfactant replacement therapy effects, predicting the need for surfactant application. Then again, there is this detection of hidden lung congestion in patients on dialysis. Lately, we're using intravenous, unfortunately not in our hospital still, we're start to use it in a very recent future, but there is a use of contrast enhanced ultrasound in complicated pneumonias, both intravenous and intracavitary. And at the end, you know that beauty exists where you least expect to find it sometimes. And when you love to perform lung ultrasound, as I do, you can sometimes see a beautiful swan within a massive pleural effusion, and a necrotic area within the lung might look like a heart to you. So this is Novi Sad, the city I come from, and I thank you very much for your attention.
Dear Professor Lovrenski, it's we who are thank you for your time again, and it was very interesting to listen to you. I hope that someday we also can perform this in our institution in Armenia. For me as a pediatrician, from my side, it is very much important. Only if we can reduce the amount of chest X-ray, it is enough to go deeper in this modality, because in pediatricians know how often we need to do chest X-rays, and sometimes we try to do less, and sometimes we cannot, and instrumental findings can help us. Of course, from our side, we also can help to interpret these findings if it's viral pneumonia or bacterial pneumonia. But anyway, if we can reduce the amount of chest X-ray, the amount of radiation, it is only from this sighting is enough. But also I can see that with help of lung ultrasound, we can see some findings earlier than in chest X-ray, and also maybe faster, and also we can how to say, follow up more often than in case
That's
of
right.
chest film.
Because it's harmless method. So you can do your follow-ups every day if you want to follow up your patient, you know.
Dear Professor, thank you very much for this great lecture. I hope we'll continue our cooperation, and we'll have you here in our department, and we'll continue our teaching process in reality. So we have one question. Is it possible to detect GGO by ultrasound, ground glass opacity?
Yeah, definitely. You know, it's now in this COVID era, it was very often seen, and you will see it as a zone of mostly alveolar interstitial edema, but not diffuse alveolar interstitial edema, but zones of smaller zones of alveolar interstitial edema. So it's possible, definitely. Ground glass equals alveolar interstitial edema most of the time, especially in COVID-19 patients and in interstitial lung diseases and etc. Yeah.
Okay, thank you for your answer. And one more question from me. What about lung tumors? Is it possible to have one more lecture to have more detailed differential diagnosis spectrum for lung tumors and consolidations?
You know, in kids, we don't have much tumors. You know, it's very rare. Actually, I don't remember. I saw few times lymphoma within mediastinum, but true lung tumor, I don't remember that I see it, and I'm performing lung ultrasound from 2008. So it's very rare pathology, extremely rare. Of course it's possible, but to tell you honestly, I don't have much experience with that because of the number of the cases. They're almost with pediatric lung tumors. I don't know what's the situation in your country.
We also don't have so many cases. Okay, thank you very much. If we have other questions, you can write here. If no, maybe to finish.
We will wait for a minute to auditorium. If you have questions, you can raise your hands or write to our moderators. Now I opened the chat. You can write your questions.
I'm just looking now. There are a lot of people listening.
Yeah.
A lot of people.
Yeah. Thank you. Thank you,
Thank you.
Thank you, Moms, in the chat. Yeah.
So
okay.
We don't have questions, I think. Okay, thank you very much, Professor. Thank you for your time you spent with us. I hope our cooperation will continue, and we'll see you next time, maybe in Armenia. We are waiting you here in our department, in our country. Thank you. Have a good day.
Thank you very much. I truly hope that we will continue with our cooperation, and we will definitely stay in touch. Good day to you all. Thank you very much.
Thank you.
Bye.
Thank you.
Bye.